Today I'm talking to Dr. Dewayne Book, our Chief Medical Officer at Advita Health, about what it really means to be a relational practice. Healthcare has drifted so far into transactions that most people barely recognize what true relational medicine feels like anymore. Dr. Book is adamant that we hold the line and remain a beacon for clinicians who want to practice differently. We dig into the basics about what actually matters: 30 to 90-minute visits, weekly follow-ups early on, and continuity with the same provider. These aren't luxuries. They're the foundation for real clinical insight. Rapport isn't something you squeeze in during a 15-minute med check. The relationship is part of the treatment, especially in a world where people feel more disconnected than ever. We also talk about what relational means inside the organization, how we treat each other as colleagues, how much time and attention goes into supervision when it's done well, why psychological safety and curiosity make clinicians better, and why being a deliberately developmental organization is not fluff, but a practical strategy for reducing burnout, retaining great people, and raising the overall quality of care. Of course, we hit on some of the bigger structural forces too, including the pressure from private equity and the obsession with productivity. Greed shows up in medicine long before anyone recognizes it, and it changes how people work and how patients feel. Our salaried model and intentional guardrails are designed to protect against that drift. Ultimately, this conversation centers on one question: what happens when you build a healthcare practice around relationships instead of transactions? Dr. Book makes a compelling case that the answer is better care, healthier clinicians, and an organization that actually feels human. Let's dive in. All right, welcome back to the podcast, Dr. Book.
Hey, Tripp.
I'm excited. You brought up we were in our quarterly offsite 2 weeks ago, and we were discussing, how do we continue to grow but keep what we think is special about us? And then I asked, what is special about the way that we're not just practicing psychiatry, but how we're trying to build the organization? And you just looked over and you said, we're a relational company. And I loved that term. And I think we've tried to build that in, but I'd love for you to tell me what that means, both from a patient care perspective, but also as an organization and how we work together.
Well, let's talk about that some. I think that the relational practice versus a transactional practice. And so a relational practice, and I think that we have relationships with the people that we work with, that people in this company have names and they have full lives and they have spouses and children and hobbies and strengths and weaknesses and fears, just like everybody. And so we don't refer to people who, we work with as FTEs or human resources or units of productivity. And I mean, it's sort of comical, but organizations will actually talk about the people that they work with in those terms. We need 2 more FTEs, as if there's a gadget of some sort, an object. And I think that if it's an object to be capitalized and monetized, then that translates then to how we look at patients. And the patients are objects to be analyzed and to not see them as full people. And I think that, the way that we practice psychiatry here is really a reflection of what the organization is as a whole and how we treat the people that we work with.
How do you think?
I think that's basically, when I talk about us being a relational practice, that's really what I'm referring to.
And since you've been doing this a little while, do you think it got less relational over time, or?
Well, like everything in the world, healthcare is driven by economics, and which is really unfortunate. The business of medicine, I think, is 2 words that really ought not be together, but in reality, they have to. That we practice has to generate enough income to support itself and pay for the people who work here and keep the lights on, in the words of Tripp Johnson. I think that, the reason that I like being here is that profit or generation of income is not the overarching goal. The biggest goal that we have is providing the highest quality of care to the people who come here, as opposed to uh, providing the highest quantity of care. And I think that this shows up in how in the with patients how we schedule our appointments. The initial appointment is 60 to 90 minutes, and then I encourage the providers to schedule a follow up with that patient for an hour the next week. Because you can't really understand a patient in just 60 minutes and then see you back in 2 months. And also, follow up appointments are not 10 minutes or 15-minute med check. If I have a 15-minute med check with you as a patient, then my only question is, everything's okay, right? And if you say anything but yes, then I don't have time to deal with it. And so the patient in that situation leaves feeling as if the providers are not attuned to them and is not attending to them. And then at the end of the day, I have generated a lot of income, but really as a person, don't really feel like I accomplished much other than the generation of income, either for myself or for the practice. So, plus that sort of system makes me very anxious as a provider, that like, what did I forget to talk about, or what did I miss here? And so, having our follow-up appointments be 30 minutes or an hour really does provide for some space and time to interact with the patient.
I guess I think, at least for me, there's a romanticized notion of the practice of medicine where I think about, probably the 1930s, and there's a guy who's got a black bag and he makes house calls. And that was old school. And then, both our science improved, but like you said, it's capitalism. So, private equities entered the game in healthcare significantly over the last few decades. And
But
because of that,
Tripp, that's a great example about how medicine began. And there was a guy in your community or your city, and you called him at 1 a.m. and said, my wife is going into labor. And then he came to that is a relationship.
Totally.
Right.
Totally.
And I think that then as, it became more of a business model, we got so far away from that some patients, at other practices really aren't sure who they're going to see this time. Every time they go, they see a different patient. And so somebody has and that's very, very transactional. And I think that doing 4 15-minute med check appointments is lucrative, but it's not good for the patient. And I also think ultimately it's not good for the provider.
Yeah, I think we've grappled with a lot of the tensions we have. Even I'll say we're not the exact same generation. So, my generation, I think it's interesting because I do think there are a lot of patients who think they're looking for transactional healthcare, right? Like there are a lot of these, mental health tech startup companies. And yeah, hey, you can do a 15-minute visit online and they'll ship ketamine to your door.
Right.
And I think like we certainly don't like that, but I think based on individual providers, some people really value in office, and I think we, in a perfect world, would do the majority of our work face to face in person. That obviously is not accessible for some people, or it creates a burden. So there are all these tensions. Like the insurance companies love telehealth because you get more access, it builds their network, you can see people all over the state. But like all of that removing friction, this is something I think about beyond the relational healthcare piece. Is so much of our society is about removing friction. Like that's what capitalism is good at. Like we want efficiency. And certainly if I know you had a DMV issue a few months back and you wished that was more efficient.
Right. That was
And so we're conditioned to thinking like we want to be able to log on our phone, hit a couple of buttons, and someone pops up and solves our problem. But I think one of the places that personally I think most systems miss the mark is it's not just that we have a relationship and you come in, but that relationship builds over time. How can you really know what meds someone needs unless you have the full context? And how are you going to understand when life events happen that this is a normal response or this is an abnormal response that's becoming, pathological and needs to be addressed medically? And, I could show up one day and you're like, this guy is definitely manic and we're going to have to IVC him. And then you realize after knowing me a while, I just had too much caffeine.
Right.
Or something like that.
I mean, here's a great example that that a couple of months ago that I had this issue trying to get my license renewed with the DMV. I mean, it was amazing. I mean, it was like eventually looked like some scene out of Shawshank Redemption just to get my. But that that about me is really a testament to the relational nature of this operation, that we know each other in 3 dimensions, the people who work for here. And it's really about that connection, getting to know the people that you work with as full people. And then occasionally I have like a group of coworkers over to the house in just like a casual way, just to hang out and bring your kids and bring your spouse, and seeing people as people, and it's not a gimmick. I mean, that's what I think, not just for me, but for all of us, the relationships in our life is what makes our life meaningful. Not how much money I can make or how many RVUs I accomplished in this week, but the relationship that I have with the people that I work with. And for me, also the relationship I have with patients. That's what makes for a meaningful life. And what people, I mean, we could talk about the people that we work with, that people need to feel safe in relationships, so that if a mistake is made, that it doesn't feel threatening to talk about that. And I had a conversation not too long ago and with a new employee, and I was like, hey, listen, you have the job. We're done. You can quit auditioning for the job. You're not at risk. This is 100% safe. Let's just talk about what's going on. And I think that, like, when you have those relationships with the people that you work with, then people enjoy their work. It leads to less burnout, and they're more available to establish important relationships with patients because they feel attuned to and also safe.
Which shows up in our the way that we think about compensation here. And I think one of the interesting challenges, and I know you're aware of all of this, but I'm curious if you have any questions. That one of the interesting challenges we have is we want people to work here for a long time, because for us to do the type of relational care we want for patients, we believe that we need good collaboration amongst our team. That doesn't happen if people are turning over all the time, because part of the value we're trying to deliver to patients is kind of a seamless experience where your therapist and your psychiatrist are on the same page around your treatment. And that's not possible if people are shuffling in and out of the practice all the time. But it creates its own, back to capitalism. The way that we approach employment is generally we want people to be full time. We want them to be paid kind of top of market. And really what we're doing as an organization is we take all the risk, because we say you're guaranteed this salary regardless. If you're coming with no patients, you still know your salary. And if you're coming with patients when you join the practice, great, you're still getting a salary. And I think that allows us to, I mean, yes, the metrics still matter. We have to see a certain number of patients to keep the lights on. But I think it allows us to focus more on becoming better clinicians, than we just need to hit our numbers.
Right. Well, I mean, I think that's transactional.
Totally.
How many patients can you see, and how much income can you generate? And I mean, I love the model that we have where we pay the provider's salary, because then you can relax about that.
Yeah.
And it also prevents, people who don't know how to set boundaries with work. And if you're on like an RVU model, then you work 60, 70 hours a week because you're so motivated or, anxious about money. as opposed to being like, here's every 2 weeks they deposit a certain amount of money into my checking account, and I can just let go of being worried about that and focus on taking care of patients, which I think is a rare. I mean, when I tell people out in the community that everyone here is on a salary, they sort of back up a little bit and can't imagine that we can do that. And I mean, I had someone said, like, how can you do that? I said, because profit is not our primary motivator, and your organization can't compete with us because you're primarily focused on how to make more money. And we're trying to focus on how to get better care. And then just naturally, I mean, I think that because of that relational practice model with patients, and we wind up doing okay financially because people want to be patients here.
Yeah, I think I'm laughing because I think there were 2 or 3 times you came to me and said, "Hey, I got this PA or this MD who's interested in joining the team, but they make a lot of money." And I say, "Well, find out what they make." And or just ask them like what they want to make. And every single time we've been able to offer them more money than they were making in this transactional model. Uh, and they just come in and get a salary that's better than what they already had,
with
which I think
with less stress.
which
That, like,
is
if a patient cancels or doesn't show up, that doesn't show up in my paycheck, and I think that that's like I mean, there's such a luxury here. So I mean, and that's the thing that you're talking about. Consistency is and low turnover is what like facilitates safety. Right. And the longer that we work with each other, the more I know about the people that I work with, the more that they know about me. And, the rapid turnover of people, and we have a very, very low turnover rate. Although, I mean, talking about this, I mean, recently there was a PA, brilliant PA I've known for a long time. And, he came and said, I don't want relational practice. I want like urgent care practice. Come in, done and go. And I said, you're so brilliant to know that about yourself. And I appreciate so much you saying so to me. And this practice isn't for everybody. I mean, some people
totally.
enjoy that. It's hard work. It's hard emotional work to develop
Yeah.
relationships with each other and with patients, that like I've got like an emotional investment in the patients that I see. And so at the end of the day, I feel tired, right? As opposed to just like doing the same thing over and over. And here's your prescription. See you in 6 weeks. I mean, I think that in some way that's easy. The other thing, though, I mean, I think that because of the way that we practice psychiatry, that we also need to be aware of that it's emotionally draining to have a series of relationships. And I think that's why having relationships like we do with each other is so reparative or healing. And so that, I was talking to one of the other psychiatrists, and she said that, God, it's been a really difficult day because patients come in and bring you their pain. And, your job as a therapist or psychiatrist is to sit there and be with that and have empathy for that and be an actual human being. I mean, I think that what I do and like encourage people to do is I bring my genuine, authentic self as much as I can into the room, not my clinical persona, right? That's a fake thing. And patients can, feel that. And if, I mean, the thing that like in practice with patients, like very, very much am in tune with that so that the next time I see the patient, I can say without looking at my notes, how was your grandson's birthday? And I mean, the patient experiences that as this person is attached to me. This person is attuned to me. And they say, I can't believe you can remember that. And I mean, I never know where my car keys are, and I'm always lost my phone. But when I'm in the room with a patient, that's the most important thing that's happening. Anyway.
Yeah, I always find it interesting because, just going back to the business model one last time is, when we moved into the office building that you're in now back in 2020, we were only doing the IOP level of care for substance use treatment, but we knew that we needed to bring psychiatry in-house because so many of our, most of our patients were seeing you at a different practice, and that we didn't think like that made sense for the patient, that we needed that all in-house. But I thought this must be too hard to do. Like this problem, like everyone would do this if they knew how to do it, right? And so then I remember working with Michael back in the day and saying, look, let's just look at Medicare, the Medicare physician fee schedule, and see what they pay for psychiatry. And we built a business model based just on the Medicare physician fee schedule. And most of our contracts are, above that. So that's a very conservative way to model it. But I started seeing like, wait a second. Yeah, I mean, the fundamental insight to me, because I had a prior relationship with you and I understood RVUs, I was like, okay, you're getting paid on an RVU model. And I thought, how could I fix some of the problems? Because I know you told me every month or every 2 weeks you had to get in a debate with the finance team about what work you actually did, and your paycheck was never right, and surprisingly it was never right in your favor.
Right. Yeah.
And so I thought, like, hey, like, can we do this a better way? And longer visits, salaried model. Yes, we have to take the risk, but ultimately, if we build a good organization, there's going to be some benefit to all of us as well. And I remember thinking, like, the math is too simple. Why are people not doing it the way that we're thinking about doing it? And the only answer I could come to was greed. That once you figure it out, it's just, I mean, once you know how to make money and you get removed, and I think probably because of the practices that get big, in order to get big, you've got to build the infrastructure out. And the types of people who are interested in building infrastructure probably got MBAs at Duke or Wharton, and they're not invested in the patient care thing. Whereas at our organization, our leadership has, like, we were living in a sober living when we got started, just to help get it off the ground because we couldn't afford to live anywhere else.
And you had relationships with the people that you were taking care of. And
Totally.
it's emotional relationship. I mean, I think that the greed, I just think has no place in healthcare. If that's, I mean, and somebody at because if I see a good provider, out in the world, or somebody that I know that I think would, enjoy being here and would be an asset to us to be here, then I'm going to find that person and take them out to dinner and say, here's what we're doing. Be great if you're a part of it. And I had a colleague at another company, say, I need you to quit recruiting my providers. And I said, I will not agree to that. Here's the thing, though, it's open. Outcompete me, pay them as well as we pay them. Give them a salary. Look at them as human beings, not FTEs. And he said, well, we can't do that. I was like, why can't you do that? He said, because we're trying to make money. And I said, there's your issue. Right? If that's your primary goal, then that's going to govern every decision that you make. And that filters down to the people. I mean, people know when they're in a transactional model, and then they will behave that way towards patients.
I think people have given us, our CFO may not like me saying this, but I've always approached it as like, how much can we pay people, not how little can we pay people. Because I want to know, like, yes, like, I want to make more money over the years, but we just spent the last couple months really trying to figure out, how can we do it this way and have it very clear that you're going to make as much or more money and be able to practice in a better way. And we still have the constraints of, insurance companies and how much we get reimbursed and everything else. But as long as you're not greedy, it's going to work out. So,
well, I mean, I think that's just like a great how if the goal is to make the most money, then I want to find out what is the minimal amount I can pay this person, and how can I get them to do the absolute most work, which doesn't show up for them, right? Then that money goes somewhere else. Uh, it's just it's just an inhuman way to treat people. I think, that this is not a factory.
yeah.
We're not like making widgets, that we're like dealing with human beings, usually who are at one of the worst moments of their life. And if I'm thinking, how quickly can I get out of here so that I can go see another patient and generate more money quickly, then it's just a contamination of something very sacred, I think. And
Well, you said that greed has no place in healthcare, and I would say that greed has no place in humanity. But unfortunately,
well, let's start with
there's a
healthcare,
lot of
and then
yeah.
we'll start
Well,
with
okay,
healthcare. We'll branch
all right.
out.
You know,
I mean, I think that there. I mean that. I think greed has no, shouldn't have, but it's going to, because I mean I think
totally.
people. I also think that blame has no place in human relationships, and I think that having that mindset when I'm talking about difficult cases with providers or something, I think the people that work here sense that I'm not to blame or to attack. We're just all here to learn and to do better, and that's about the safety of that relationship, I think.
One of the
Go ahead.
one of the things I was going to say that I think is the interesting challenge that we've identified organizationally and started talking about is the idea that a lot of times small practices are relational. Like, yeah, that's the nature, and that's the nature of starting an organization from the ground. Is you're all in it together.
Right.
But the problem sometimes with that small organization is it doesn't actually have all of the resources to do the type of care that you want to do. So to me, the interesting challenge is, how do you grow the organization to be well resourced, to be able to treat everything that comes in without losing what makes it feel special when it's relational? And I think that that's that's the challenge I would have for anyone who's in a leadership role in a behavioral health organization, is know that at some point you got to be big enough to have the resources to treat people. You can't have a TMS machine and only one TMS patient a year.
Right.
You're just going to lose money. But if you don't have TMS, then you may not be able to actually have that longitudinal relationship and say, hey, the SSRIs aren't working. Why don't we try this? You've tried therapy, but you get to stay in this organization, and we have your full kind of history, and we can work through that together. So yeah, I just find that like one of the interesting things is, like, once people start growing, or that it kind of flips. I think they start, like, I think most places start relational. No one says we're going to be a transactional practice to start. Uh, but it often kind of goes that way if you don't have the guardrails to protect the practice. So, like, that was one of the first things that I did, was like, what are the guardrails we're putting on this? Because I'm not a licensed professional. So we talk about the visit length. We don't put providers in windowless offices. Uh, there's a lot of like little stuff that we do to kind of protect some of the sanctity, so that the human nature, our greed doesn't get in the way, that we have those guardrails. And I'm as we talk about a new office and everything else, I'm just thinking a lot about how do we protect what's special, and then challenging ourselves to say, is that thing, whatever we're pointing to, whether it's the relational piece, whether it's how we, the length of visits, is that the thing that really matters or not? And I think we're working through that, and I think we've got a strong hypothesis now.
Well, I mean, I think we're swimming against the current, right? And I think most people start off like as relational, and I mean, the thing that I have seen is that when a private equity firm comes in and offers like all this money, now you've contaminated this relational practice with some outside entity who is financially invested and financially demanding that you perform in a certain way. And so we're sort of answering to someone who's not in the room. I mean, I think the thing I love about AIM is it's just us. Right? And so if you say to me, I'm going to take care of this, then a couple of days from now, I'm going to see you and say, hey, I don't have to call somebody in California or send an email, and nobody's going to call me and say, you didn't make enough money this week, start doing things differently because we have shareholders. I mean, I think that all that stuff really affects the people that work in organizations like that, and then ultimately winds up affecting the quality of care that patients have.
And from you hit on a couple of things, because let's see if I can say this without sounding too ridiculous, but the problem with private equity and the problem with the profit motive, I don't necessarily, obviously, like, we all need to make money to survive. But the problem with private equity, where it's especially perverse, is that not only do they need to make money, but they're going to sell the company in the future. I mean, there are some, but very few long-term hold private equity. So what they have to do is they actually have to increase the, financial performance of the organization to sell what they're now looking at as an asset for more money in the future. So where we can be happy, like, we can be happy growing and breaking even. Other people have to grow and make money at the same time. And then you look at the time horizon, and private equity, usually their funds are like 5 or 7 years, meaning they're going to buy you and sell you within 5 to 7 years, which means you have to be a lot better for them within that tight time frame. And I would even say, if you put on a ruthless, cutthroat capitalist hat on, I would say that they're still wrong. Like, you could make more money doing it relational, but your time horizon is very different. So the question is, because they're borrowing money, so they're already paying debt service on the money that they've borrowed. So they need you to make money to cover the debt service, and then they need to make more money to sell it in the future. Whereas we've just cut out, like, when you say the shareholders, we've cut out that pressure, but also the fact that, like, we aren't levering up just so that we can, we have to cover more and more growth.
I mean, I sort of have a vision when you're talking about that, about me being in my office with a patient in this room, and the door's closed and the blinds are closed, and it's very quiet, super safe. But then it's almost like outside of that room, there is this bizarre war going on, with not here, but, that, like, this person's not seeing enough patients, and, all the sort of, we got to make this place turn around in 3 years so that we can get, and yet I'm just in this quiet room attending to a patient in the middle of all of this sort of economic noise that, I mean, there are great and easy ways to make money in the world. Go, if that's your goal, go do that. But don't, you know what I mean? Like, be a stockbroker, or like, go be a lawyer. I mean, there are ways to make money. I mean, when I, first was interviewing for med school, I mean, I was, I guess, 27 or 28, and, was functionally an adult, I guess. And, during the interview, when they said, why do you want to be a doctor? I said, I want to help people. And it was almost this, like, in medical school, it's a ridiculous thing if you were doing it just because you wanted to help people. I remember having this vision of, like, writing that on a piece of paper and locking it in a box. Like, I just imagined that, because it's a really difficult journey, and, everybody becomes cynical and exhausted and all that kind of stuff. But I remember having a vision of putting that in a box, and when that process, that 8-year experience, was over, having protected that goal, and go back and open that box and put back on that goal. And if my goal in being is just to make a lot of money, and if I help people, fine. I mean, for me, and I think for a lot of people here, it's much different. Like my goal is to help people, and if I make money, then that's good. I mean, I want to make money. Everybody wants to make money, but I think if as an organization, if that's our primary goal, I'm going to ask you this: like, how do because when I'm like talking to new providers, everybody has post-traumatic stress disorder from having worked at an organization that got bought out by private equity, and the whole environment and climate and that organization changes. What prevents you from doing that? I always assure people we're absolutely not going to.
Yeah, I think it's a really interesting question. And the first thing I would say is I just have no interest in it. And I'm young. And the I I agree with the statement. There are a lot of ways to make money. This is the way that I've chosen to make money for my family and everything. But I am very clear about how much money I need to make to survive. And I am young and healthy, and I don't have any pressure to make, more than I need. At some point, like if we fast forward, 20, 30 years, am I going to sell to private equity? I don't know. I cannot promise you that wouldn't happen in 30 years, but I can tell you it definitely won't happen in the next 10 years. And I think in my mind, like I would come, let's say it is, I am thinking like I'm ready to move on. I've worked hard. I think I would think about like how much money do I need to sell this for? Do I need, or do I retain ownership? I could turn it into an ESOP, which is employee stock owned something. And like, could I sell it back to the employees? Sorry, let me answer this more succinctly. I am not selling to private equity because I think that we have the ability to continue growing without selling out. I think most people feel a pressure at some point that if they want to continue to make more money, um, they're going to have to sell to private equity. They're going to need more money to grow the business. And for better or for worse, and my wife might say for worse, but like I'm willing to take the risk to keep growing the business without changing the incentive structures.
Right.
Like there is a very, you talk about like the sacred practice of medicine. And I would say like I feel that there is I have a philosophical sacred calling to show that there is a better way to do it, because ultimately, if everyone copies us and we are no longer unique, then we've done something great for healthcare.
Right.
And then we can continue. I would like to say we're really raising the ceiling on what's possible, but sometimes all we're doing is raising the floor and showing people that there's a better way to do this. And I guess I just have a trust in the universe that if I do the right thing, it's going to work out. And it's kind of naive, but I think what I've learned over the years of this is you get a reputation for that, and other people, when you're struggling, then want to help you out,
Right.
because you're trying to do the right thing. And it all sounds very Hallmark card-esque, but like that's kind of how I think about it. And I've actually been thinking, because you say that where when people have had traumatic experiences with organizations selling to private equity, I was thinking a few months ago, maybe every year or every 5 years, there should be a pledge like we're not selling to private equity in the next 5 years, because, then, hey, we're either renewing that pledge or that could happen, because I hate to, I hate to paint all private equity in a bad lens, with the same brush. But ultimately, if you have a time limited fund that is going to sell the asset, their goal is to obviously sell it for more and significantly more, because they have to cover the leverage. And that's just not a game. It's just not that interesting to me. Like I get the game. I have friends working in private equity, and I just can't imagine I can't imagine showing up and being interested in the problems they're solving, because they're very like one dimensional.
Right.
Like you're just looking at Excel spreadsheets and saying, how do I make these numbers look better? And that's simple in some ways. Like in some ways, I get the appeal. It's you're just looking at numbers and it's a sober calculation. But I like the complexity of humanity. I like the friction. I like trying to figure out, like, is our waiting room looking the way that we want it to? Are our people happy? Do they feel like they're growing in their clinical skills or not? And that's a very interesting problem. So I'm not telling private equity because I like to make my life more difficult in pursuit of a much more interesting goal.
I mean, when you talk about that and you sort of like, sure, I mean, it sounds like a Hallmark card or something. I mean, I think that's what really can be different with us is that, this naive goal that I had to help people to really embrace and celebrate that, and your ideas about being an organization and then sort of have the little asterisk, but this sounds like a Hallmark card. Yeah, it does sound like a Hallmark card. Some of that's good stuff, man.
Yeah.
I mean, I only went to to practice medicine to help people. That's it. Right. I mean, and that's like honorable and I'm proud of that. And I don't care that all those people are like, I'm going to make money. And I was like, I'm just here to help people. And I think that, but that's hard work, but then it really makes for a meaningful life. And I think for me, having, all of these relationships that I've had with patients over the years, it makes for a very, very rich life. I mean, I think that if you're good at what you do, the money will follow you. I told my kids one day, I said, listen, if you chase money, you may find it. You will definitely find it if you chase it, but it may not be attached to happiness.
Yeah.
And I think, if I made 3 times as much as I made, but didn't really feel like I was contributing to people's lives in a meaningful way, then that would be, I think, a very superficial life. And as an organization as well, this would become a superficial organization. And I mean, if you can find a private equity firm that has that same value, be great. That we have unlimited resources and stuff. But I just don't think that animal exists. I mean, there was when I worked in the substance abuse council for the state of Louisiana. So this was a state clinic, and so whatever picture your mind just painted of a state clinic, that's probably pretty close, right?
In Louisiana,
small windowless office and 80 million patients. And I went to work one day, and the patient was wrapped in a shower curtain on the back steps, waiting for us to show to work. It was in the middle of the crack epidemic, So I didn't ask for your insurance card or any of that stuff. But there I had like more patients than I could possibly see, and every possible appointment was booked. And then, the governor laid off a third of the state employees and blah, blah. Anyway, so then I went to work for Charter Medical Corporation. And I can say that because I don't think they're in business anymore. And when managed care showed up, they just took the money and ran. But I took a job there, and that clinic, my office was 4 times the size. And it was just like meticulously decorated. I remember like there was a brass antelope, and just like the contrast from where I had been to where I went. And then there were no patients. Like I would go like 2 days without seeing any patients because nobody could afford to, the services. It was just such a contrast to how it felt to have unlimited resources with that private for-profit pre-managed care era of the world to a place where we were really just focused on taking care of people regardless. And just that contrast there was really jarring. That having unlimited resources didn't really translate into good patient care.
That's one of the things, I think about as we're out of space in our Raleigh office, and we're looking for the new office. One of the real benefits from, even in my position about being this relational company is if we can tell people, hey, it's gonna, like, we're a little tight right now. We know we're kind of stretched thin, but here's what we're going to do.
Right.
And they trust that we are going to follow through on that. Then people really work better together, right? And we're able to grow, and people, I mean, the thing that's so impressive to me, and I think there are times even in our organization where, I mean, it wasn't as much like this, but people really have each other's backs. I mean, we went through we just got done with the Joint Commission accreditation, our 3-year survey, and it's always chaos. I mean, it's just, they're coming through all our records, looking at the facilities, all of that. And, Nick and Corey were in the room together, but if they needed anything, they just pinged someone who's not in the room and they came and delivered it. And again, you said there's not that room for blame in a relationship. What I'm really proud of right now, and I've been kind of quiet. I used to send out these weekly, emails, and I want to get back to some of that. But I've really taken a step back because I'm trying to just see what's happening and what's needed from communications. Because, I think like one of the beautiful things, and we may differ on this some, but as we talk about kind of how we're looking at growth, but I think one of the beautiful things that we have right now is just that people are truly working together. I mean, it's been really inspiring, and it's kind of like I don't know what to do because I don't have to tell people to work together. I don't have to like paint the picture for what working together looks like because now that's kind of baked into the ethos.
Well, but I mean, I think that, that at the beginning of, this organization that you and Nick really established that. And so everything that came out is just like modeling the system that was in place. And I don't know that you intended that or you had like a spreadsheet that told you what to do on what day so that you do that. But I mean, I think that's the part of being a relational practice that like, Joint Commission coming and like digging around in your trash can is like stressful for everyone, right? But Nick and Corey, who really spearheaded that and took care of that. I said, listen, I'm here if you need something. If you have a question about something, call me. And then hug them. Like hug Nick and hug Corey in the morning. And it's like, this is going to be great. We're doing fantastic work. This is an opportunity for Joint Commission to see that. And everything's great. Everything's fine. And so there was like one question that he had, and I just like looked at the patient's chart and I was like, oh, here's the answer right here. And this is why this is the appropriate thing the provider did. And write this down and take them back. And if you need me to come over and do that, that I'm here. I mean, I think that we have gotten so used to having those kind of relationships that the people that we work with, I think sometimes we forget how unique that is as an organization to be able to have those kind of,
Yeah. And that one of the things I've been saying more recently is I've gotten, everyone used to be my age, and we were all young. Now now we're hiring people who are a lot younger and some that are older. But one of the things I'm looking for now sometimes is like I want people to have work experience, not because like I just need the experience, but I think when you're young you can be incredibly idealistic and generally in a good way. But then the world smacks you over the head and you just learn the lessons about paying a mortgage and, getting a flat tire and everything. And so money does matter at some level, but we all want that community. We want that relationship. And if people haven't worked somewhere else, like they don't know, they may not understand that this is a value. Like this is something that we're doing that's different. And so, one of the things, it's not like I want people to have a bad experience, but if you're overly idealistic, like we still got to see patients, we've got to hit certain numbers. And if some other organization can make that even easier on you, great, go do it. But just show me who they are that's also treating a commercially insured population. And I'm going to talk to them and I'm going to say, how are you doing this better than we are? I want to know how you're doing this better. And so sometimes those people come in, if they haven't had that experience, you can still be like a little jaded because whatever they're putting in you, in school is not always in line with the economic realities of being an adult in America today. Right. So it's an interesting thing.
Yeah, I mean, I think that some people, when they come here, they've worked other places, they almost come in, they've developed a set of tools to function in an organization based on the other organization. And they're out of place here. They're not needed. Do you know that we're rooting for you? We certainly want this to be a fantastic place to work and to enjoy. And that's our goal. And then people come in, ready to like, what do you mean by that? Like, I mean exactly what it sounds like that I mean by. Yeah, I mean, I think one of the things, that's really like how we supervise people that, the medical board says you have to once every 6 months meet with your APP. And I meet with my APPs weekly, and I meet with them for an hour so that I can get to know them and they can get to know me and I can learn from them and they can learn from me. And it's not in a threatening supervisory role. We're just two people in a relationship with a different set of skills and a different set of information. Together, we're better for knowing that. And yeah, I mean, I think that in getting together outside of work and going to dinner or like coming over to the house or something that's really getting to see people in 3 dimension. Like I had like a holiday party at my house, and one of the other psychiatrists said, "Hey, I have a piano at my house too," and so he said, "Hey, I want to rewrite the words to it's beginning to look a lot like Christmas, but I want it to be aim related." And I was just like, let's do it. Like that's, yeah, man, that's who we are.
Yeah.
That we can do stuff like that and enjoy each other like that. And because everything outside of the room where I see the patient is taking care of itself and it's not like war, then I can focus on that.
I'd like to talk about that supervision a little bit more. I have some understanding of what it looks like in other organizations. I would be curious to dig in, like in the past, how were you compensated for supervising APPs?
Well, the previous organization had just paid a certain amount per month.
Mm-hmm.
And the more people that you supervise, then the more money that you made. And
Mm-hmm.
so if you were supervising 10 people, then you made a lot of money. All right.
And did you also reduce like your patient care hours for
No,
that?
because the patient care hours are just fee for service. If the
Mm-hmm.
patient's in the room, you're making money. If the patient's not in the room, you're not making money. And if you spend an hour a week with the people that you supervise, that's an hour that you're not making RVUs, right? So, and since the requirement is once every 6 months, let's just do it once every 6 months, right? And then we can also do it as a group. All 6 of us are going to meet online in a group for an hour every 6 months. And each of these APPs has between 1,000 and 2,000 patients, which means that there are 12,000 patients on my medical license, none of whom I've ever seen. And that's just like terrifying because you have no idea if this APP is doing it correctly and what mistakes are they making. If there becomes a complaint, then you open that chart and look at it. But
But
here,
you got to, yeah, I mean, you got to pick your APP. Like they consulted you before hiring people, though, right?
no, of course not.
So they
I
would put
mean,
people on
here
your.
here are
They'd
the
put.
APPs that you're going to supervise. Yeah, and I mean, there was a interesting dynamics of that because there was an APP that I was supervising who was a drug dealer. I mean, essentially, 100% of those patients were on Xanax and amphetamines, and he was seeing them for once a month. And I mean, he was like the highest producing APP in the organization, and he was signed to me. And after 2 weeks and looking at some charts, I just went to the medical director and said, "This guy's coming off my license today." And he said, "Well, we're working with him and we're trying to," I was like, "That'd be great. You work with him on your license. Uh,
Mm-hmm.
and can you give us a couple of weeks?" I said, "You can give him as long as you want, but he has to be on your license because he's not being on my license." And
Mm-hmm.
they wind up terminating him because no one felt comfortable with how he was practicing. And that sort of thing can't happen here, right? Because I see you in a week, every week I'm hanging out with you and we're talking about, you know, your, your patient load. And I think, if an APP has a very difficult patient, then, having an hour with them every week, I'll say to the APP, what does it feel to be like in the room with this patient? Or you seem like you really don't like this patient very much. What's going on? What is there about you that's causing this reaction to this patient? I think that, we got a group of people that are curious about themselves. And this idea of countertransference, I mean, transference is what a patient assigns to you based on their experience. Countertransference is when the provider begins to have, and I see it with myself all the time. Like a patient comes in, and within 5 minutes, I think, I love this patient. This is going to be so great. Well, I don't even know this patient. Then I realize, there's something about her that reminds me of my Aunt Laverne, who was so sweet and kind and loving. And so now I assigned those positive feelings I have about Aunt Laverne to this patient who just sat down in my office. That has nothing to do with this patient. But I think that like part of my job is to know that about myself. And I have the other things like suddenly I don't like this patient. What is there about what's happening that's causing this reaction? I have like a couple of things that I try to hold on to in relationships with patients is that maybe not just patients, but people in general, that people are either giving love or asking for help. So when a patient is angry and, uncooperative or non-compliant or super aggressive, this is a patient that's asking for help. And, because of their history and maybe their caregivers when they were young, they learned some really maladaptive ways for asking for help. And all patients are always asking for help. Even when a patient says, Dr. Book, I love you so much, you're so great, they're just asking for help because, that the relationship with a patient is one directional. I mean, I'm engaged with it, but it's all about what the patient wants and need. I mean, I have this thing that I say, when would you like me to see you again? They'll say, it's up to you. And I said, okay, well, I'm going to see you every day, twice a day until I get my car paid off. And they're like, back up. It's like, this is not about me. What do you want? And what do you need? And I'll see you in 6 months. And I was like, nope, I don't do that. There are limits to what, but I mean, I think that just like not all providers want to work in a relational practice, that not all patients, want a relational, situation with their care provider.
Let's click. There are two things I want to hit on. I want to hit on the supervisory relationship, and then I want to hit on how we work with patients when they're coming to our practice to establish their patient-provider relationship. Let's take the provider side first. So, as you just said, there are some folks who don't necessarily want to work in a relational practice. There are some, especially if we're as nurse practitioners and PAs get more autonomy to practice independently to some extent. Like there's a big push for that, and there are certainly reasons and especially access and to care in rural communities where we need physician extenders out there.
Right.
So some people don't like supervision is what I've gathered, but I don't think I think for us, like if someone doesn't want supervision, it's a red flag, not for them necessarily as a provider, but for how they're going to fit into our organization. Because I think one of the interesting things that we've tried to build in as a kind of a parallel process to the supervision is like we actually kind of that's how we manage the team. We everyone does weekly one-on-ones. Everyone who reports to me meets with me every week. So we do this, and thus we do that on the clinical supervision side. But some people don't want that, right? Like,
well, I mean, but yeah, some people don't want that. And, when I'm like, talking to a prospective, member to join the medical team, I talk about that. about, I'm gonna, you're gonna meet your supervisor weekly. And they're like, well, I don't need that. And I was like, well, that's okay, but that's how we do it. And what is there about meeting with your supervisor once a week that you're opposed to? And
Right.
this really goes back, to their previous supervisor, or even further back to their early caregivers. And so, and the people in the supervisory role are sort of in an authority position. And then as I show up as a supervisor, I bring the person's entire history with every authority figure into that room. And then their ventral vagal system, is completely activated, and the dorsal, and they feel nervous and, at risk, and they don't feel safe. And so I think that the more that the more that I meet with the people that I supervise, their level of anxiety goes down, and they see that, this is just about us and enhancing your skill. And you can't really get it wrong. And if you get it wrong, that's awesome, because this means this is something that we can fix, and that you'll never get it wrong like that again. Not because you're in trouble, but because now and when people know better, they do better. And I think that, and I learned things from the people that there's a group of brilliant.
Oh, totally.
And I'm like, that there's a couple of people here I'm a little intimidated by how smart they are. Like they're going to find out I don't know. But I mean, and I don't think it feels like I'm in a supervisory role. I think it feels more like a collaboration between people in a relationship.
And I think, like you said, without the blame piece, I just read a quote: "If you knew you had to fail 10 times before you succeeded, how quickly would you want to fail?" And it's like, well, let's just knock that out, because then I'll be succeeding.
That's what I tell. People looking for work. I was like, listen, there is an unknown number of no's before you get to a yes. And so that you got turned down, that's awesome. That's one no out of the way. And I don't know how many it's going to be till you get to the yes, but it's a finite number, and you just knocked one out of the way. So, and not because, I think that all of our, strong relationships really come from stress. And organisms grow not when, everything's great, but when there's some stress.
And I think
this is like sort of Hallmark cardy, but the ship is the safest when it's in the port, but that's not what ships are for. Right. And I think that, like, being on a journey and there being some rockiness in relationships is what make people really dedicated to those relationships. And I think that your work family is a microcosm of that.
Yeah. Oh man, I just lost my train of thought on this one. One of the things I think, like, with our supervision structure and the way we approach it, like, as an organization, beyond, the practice of medicine, one of our core values is growing in self-awareness. And we, like you said, we've got a lot of people who are curious and want to learn. And this self-awareness, curiosity being another core value, but this growing in self-awareness, not everyone wants to do that. Right. Like, there are a lot of people who are just like, I don't want you to look at what's going on with me. I'm going to show up and do my job. But now we've kind of built this critical mass of people who are into that. Right. Like, they want to learn and they want to grow. And I think if we look at the way people communicate, whether it's in the EHR or on Teams, it's very cool and collaborative that people aren't afraid to ask for help. Like, I would even go so far as to say, I'm thinking of one person in particular who came in saying, I'm great working with all these acute patients. I can do, whatever you need. And now they're one of the ones who's taking the most advantage of their supervisory relationship. And they probably just never had that in the past.
Right.
And it's an interesting switch there where, like, you didn't know you wanted that, but now that you have it, you're like, oh wow, like, I get to grow in my skills and in my own self-awareness about what I'm good at and what I'm not, as long as I'm willing to engage in this relationship.
But they have no frame of reference for this is how this could be. Then I go to the clinical consult for the SUD program every week, and it's the med providers and the therapists, and we talk about difficult patients, and I say, okay, there are some patients who are doing really, really well. Like every once in a while, let's talk about them, okay? Because otherwise, it feels like, and one of the therapists who is young and starting out, and she's like, patient is saying this, and I just don't know what to do, and like I don't know what to say, and it was about medication, and the patient wanted it, and I just said, listen, that feeling that you have right now, that you sort of feel lost and you don't know what to do, it's because you're being invited to do something that you don't have the skill to do, and it's not your job. And that's really informative because you're going to have it again and again and again. And I have it, right? And when patients are asking me to do things and I'm like, I don't know what to do here, I have to like think, well, maybe this is not something that I have the skill to do, or is my job. And so, but not like this is not how you do this, and from now on, don't ever talk about a medication. But like, hey, listen, pay attention to how you're feeling right now. And every time you have this feeling, ask yourself, am I being asked to do something that's not my job? Am I being invited into a lane beyond my skill set? And that's perfect. Just pay attention to that. And I think like, approaching each other in that way, uh, and then I mean, I think people that I work with seeing me as a fallible human being who is not afraid to be vulnerable and admit to what my shortcomings were, sort of give them permission to do that too, because they feel safe where they are. If if Dr. Book is like feeling inadequate about something in a situation, then it wouldn't be that out of the question that I might have that same feeling occasionally. And it doesn't mean anything. It's just like informative. But I think that's we want people to work here that are curious about themselves and who want to develop better insight into themselves. And it's a great place for that because we're always reacting to each other.
And if you don't want it, there are plenty of other places that are transactional.
Yeah. And not only, I mean, I can't imagine people not wanting it, but some people don't want that. And that's awesome. And if you know that about yourself, then this is probably not the place. If you just want somebody to do the billing for your private practice and you be off in an island seeing patients, and that's not what we're interested in.
Yeah. Tell me about how this shows up. I know one of the things we've worked on is kind of standardizing that patient onboarding experience and putting the relationship at the forefront, where you know some places like you want people to generally come in once a week for a little bit, even though they don't necessarily have to. But speak to a little bit about how let's say I'm a new, I could be a nurse practitioner or a psychiatrist, but how do you coach someone into establishing that relationship?
Well, I mean, I think with from a provider standpoint, I will just model that behavior and say, listen, people are very, very, very complex. And unfortunately, I'm not a smart enough guy to spend 35 minutes with a patient and completely understand everything about this patient and what medication they need and what their diagnosis is in 45 minutes. Apparently, there are psychiatrists who are smart enough to do that. I'm just not one of them, right? I need more time. And so I will see the patient either for 90 minutes or 60 minutes the first visit, and then really want to see them back in a week for another hour-long session. And I think that patients experience that as, this guy's really invested. This guy's really interested in me. And uh, and then I see patients like then weekly, for a month, so that by the end of the first 6 weeks, I've seen the patients, this is an ideal situation. And of course, like there are variants always appropriate for everybody. By the end of that 6 weeks, the patient knows me and I know the patient, and the two of us have established a relationship. And because of that, I have an extremely low no-show rate. Patients do not want to miss, an appointment with me. And if they do, it means something, right? It's a message to me about something. And I'll see like patient that after they cancel or don't show, I noticed you didn't show up for your appointment last week. It made me wonder about what we had talked about the previous week that might have been distressing for you. Can you talk about that? I mean, I think part of what, strong relationships are built on is safety. And part of that safety is predictability, which means that I am on time for my appointment and I end at the certain time, right? And I try never to call in sick or to cancel a patient's appointment because that feels like something to the patient. But I'm also, if you're 35 minutes late for your appointment, I'll still see you, but you only get, the 25 minutes. I'm not going to like make all my other patients late for the rest of the day. And I think that, like we talked about earlier, those emotional relationships are very taxing to me and to the providers. And not everybody wants to do that. And so this is probably not the right place for.
Let's walk through the
judgment about that. I mean, it's just that that's not how I do it, and that's not how I want the people who work here to do it either.
Let's just go through how we approach ADHD for a minute. Someone comes in because obviously everyone can diagnose themselves now if they open TikTok or Instagram.
Right.
And so they're already sure they have ADHD, but they come in, or again, maybe a more generous interpretation being, hey, I'm having some attention issues, either work, college, things are getting, seem unmanageable.
Right.
I've heard I might need, help with ADHD.
Right.
And so how do we go about that? Tell me about, ADHD in the general population and the steps you take.
I mean, there's all these like quizzes that you can take online. And I mean, essentially they say, do you think you have ADD? Check yes or no. The thing about attention and concentration and focus is that those could be symptoms of other diagnoses as well, right? That not all attention is attention deficit disorder. Patients come in and they think they have dementia because their memory is bad. Well, I mean, memory is really two parts: is gathering the information and then storing the information. The implication being on having memory problems is that I have a storage issue. But frequently, patients are having an inability to gather the information because, they're so depressed that they can't attend to what's going on outside of themselves. So for attention deficit, first of all, every patient comes in, gets a drug screen, right? So I want to make sure that the reason you can't pay attention is because you've been smoking pot all the time, right? So, and that would certainly cause symptoms that look like attention deficit. And then patients come in and say, I have attention deficit. I need a prescription for Ritalin. And I'm like, okay, so time out. Let's talk about how this relationship works. You come in and you say, Dr. Book, I'm suffering. And I say, tell me, in what way do you suffer? And then you tell me the symptoms that you're having. And then I absorb that information and put it into my head and add it to my education and my experience. And then I come up with a diagnosis. And then based on that diagnosis, I come up with a treatment plan. And then I present you a treatment plan. And then we agree that if you come in and say, hey, give me Ritalin, I say to patients, you've mistaken me for a drug dealer. That is not who I am or what I do here. We'll do a full psychiatric evaluation on a patient to rule out any other major psychiatric diagnoses, and then have the patient do, for example, like a CNS vital sign, which is a 30 to 40-minute computerized test, which is not, do you think you have ADD? It's actually skills, right? And it's very difficult to do,
and if you try and cheat it, you can tell. I remember Dr.
I had a patient who said, I'm here for Ritalin. And I was like, had that conversation. I was like, let's get a CNS vital sign. And he came back and he scored in the number 1 percentile in everyone.
Which means you have an IQ of 7 and you're on a feeding tube and can't breathe on your own.
I said, so here's the thing about the test that we learned. Either you really didn't understand the test, or you were purposely trying to have severe symptoms, or you need 24-hour supervision at all times. And I don't know which one of those is, But if this is accurate, you can't get in your car and drive home because you're so impaired. Would you like to take the test again? I mean, I think that that attention deficit is a real thing, and it can really impair people. With patients who have a history of substance use, then it's not the right thing to give patients with a history of addiction and amphetamine.
Yeah, let me go back to that in just a second because
Okay.
I just want to contrast that. I remember I was talking to my cousin a couple years ago, and I've talked to plenty of people who, and I remember when we were in really tough financial times, I uh, was very stressed out, and I, scheduled some online, psychiatric appointment. I got on, and their video didn't work, and so they said just call. So I called, and they were willing to prescribe me basically anything I wanted within the first 5 minutes. And I was like, whoa, 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 whoa! Actually don't want to be on meds necessarily. I just want to talk to someone to like have them tell me like you don't need to be on meds today. Right, like I was so frazzled, and I just remember getting off the call and thinking like that was alarming. But on the flip side, like some people, they're like, hey, I'm stressed out, I want to take the edge off, and they're very happy that they can get that prescription for Xanax, in 5 to 10 minutes, or, they need to perform better at work and they can get those amphetamines in a few minutes. And that's what some people are looking for. But it's, quite frankly, it's alarming to me. And I would compare that kind of to the private equity example in it's all about the time horizon. So if our goal is long term flourishing for a patient, then it is extremely immature to think that a little pill that I'm going to take is going to help me flourish long term.
Right.
It may do something right now, it may help something right now, but is it setting me up for success? Where do I want to be successful in the next week? Is that my concern, or do I want to be successful, 3 years from now and in the future? And I think those are two
I think
very
as a
different
provider, you
things.
can't know that answer in a telephone conversation, right? I
Exactly.
mean, the
Exactly.
implication being that you were born with Adderall deficiency, and
Right.
now I gave you the Adderall, and you're no longer deficient, and now you're a complete flourishing human being. And I think that's, but from a transactional model, I see you for 30 minutes, and I charge for a full psychiatric evaluation, and I give you a prescription, and I write it in 10 minutes. You come back and do again, and then that sort of leads to a lot of financial productivity for the practice, but does it really foster human flourishing? And there's so many things that can mimic attention deficit disorder, generalized anxiety disorder, post-traumatic stress disorder. If your dorsal vagal system is like overfiring all the time, then you're not going to be able to pay attention, right? And so amphetamines are not going to like fix that. There's something much bigger going on, and some patients just want the prescription. And I generally don't work with those patients because, frankly, it's not very interesting to me as a provider. I didn't go to school for I did to become a prescription writing service. I mean, that's like super boring. And people are more interesting than
Yeah.
just that. And I think that's where the richness of you know, a life comes from.
I think we may do a whole episode on this one, but like, let's see if we can do 5 minutes because I'm very interested. We've talked about it some, but you mentioned like the substance use disorder plus ADHD. Um, I'm curious. I know there's kind of a general way you conceptualize this, and everyone's got different approaches to it. But yeah, tell me like someone has a history of addiction. They come in, and you generally think they have ADHD, or you just take it from here. Let me let you cook with that.
Well, okay. I mean, it depends, right? If you have a history of addiction and you're 20 years abstinent, and then you suddenly at 55 decide that you have attention deficit, then that's something we probably should talk about. But the majority of patients that I see are patients who have been abstinent for a week.
Mm-hmm.
And their entire neurology is just they've been waging chemical warfare on their brain, and of course it doesn't work. Right, your brain is
Mm-hmm.
not working right. This is this concept in medicine and particularly in psychiatry called parsimony. And parsimony is the fewest diagnoses to explain the most symptoms. But a patient in a week of abstinence, I could take the DSM 5 and convince myself that they have 18 different psychiatric diagnoses, right? Particularly if I don't consider the substance use. Patients, a history of cocaine and amphetamine dependence the first week, they're extremely depressed. And they would certainly meet criteria for major depression. Unfortunately, there's this line in the DSM 5 under every diagnosis, and I'm convinced it's in all DSM 5, not just mine, that says unless these symptoms can be better explained by a substance use disorder or a medical condition, and how so many providers ignore that in their DSM 5 is baffling to me. So I think where you are in your abstinence, and are you abstinent? And also what else may be going on. This post-acute withdrawal in general accounts for most symptoms. You
Mm-hmm.
know, I had a provider recently about a substance use patient who said, I think they have a personality disorder. And I was like, well, maybe they do. But why don't we wait until they've been abstinent for 2 years and their brain is working right before we decide if they have a personality disorder? If I'm having a grand mal seizure, right, in the middle of the floor, that is not the time to assess whether or not, I have a movement disorder. Let's get the seizure disorder under control and then see what there is. I don't know if that's
No,
answers.
totally. I'm going to say we're going to do an ADHD and substance use disorder episode, because I think there's a lot to dig into, and I think there's a lot of information you have about how you approach it that needs to get in the world, in the sense of I've heard you sit with the way you approach it with families, like, you've got a 20-year-old who, had to drop out of college to go to substance use treatment. Now they're back in college and they need ADHD meds. And the parents are like, well, they need to be successful. And he's had ADHD. He was on meds before. And I think it's just a really interesting, because it's such a nuanced topic, and we could talk about,
There are lots of really effective non-amphetamine interventions
right.
into ADD. And if a patient has never had an amphetamine, they report, this medicine changed my life. I had a patient who has attention deficit, never diagnosed, put her on a non-stimulant medication, like a very unsophisticated medication. I saw her back, the next time, and she said, this medicine has changed my life. She never had an amphetamine. But patients who have had an amphetamine across the board report this medicine is not working, which means they're not experiencing the dopamine explosion that they love so much. But if you take these patients after they've been on a non-stimulant medication, even if they've had a history of substance use, and then go back and repeat the CNS vital signs, their scores dramatically improve. Yeah. So objectively, this medication is working. Subjectively, it's not as fun as Ritalin.
Yeah. Yeah.
Well, we can do a whole.
Yeah, that'll be a good one, because I think there's so many. I just remember back in the early days how many patients we had who's, again, they're in school and they think they need it to, go to school. And even just how we, I think you have a very nice approach to, we're going to try the non-stimulant if we, really think we've got ADHD going on. And then, we're definitely not just giving you the, quick release.
Right. Well, then you want to do like extended release, and they even have like medications that have a 12-hour delay before they work. So you take the medicine at night, and in the morning, then the medication is active in the morning. So they're not addictive, and very low abusable potential. If you smoke crack at 8 o'clock at night, you don't get high until the next morning. You're not going to figure out that that's the crack, right? There's also like transdermal chronic flow release of this. And so I think that it's not an absolute no, but giving immediate release amphetamines to people who have a history of addiction is setting them up to relapse. And when they relapse, then you have to own that as a provider. You caused that. And, and patients are often very upset that you are not giving them their drug. And, and I'm not really here to be loved or to be friends. I'm here to make the right medical decision. But, as a provider, it's a lot easier just to say yes and write the prescription. It's a lot quicker. It's a lot more efficient. I'm going to get a better Yelp review, right? But if I say no, I have to explain why I'm saying no and educate the patient about that. And I mean, I think that if a patient has a relationship with me, then they wholeheartedly believe that I have their best interest at heart, and that I, despite the demand, will not prescribe something that I medically think is dangerous.
I've always said, when I've talked to med providers in the recruiting process, or even just telling them about AIM and how we practice, I often say something along the lines of, I think there are certain psychiatrists or people who've been trained who think that their job is to titrate the chemicals in your body. If they just get that right, that is their job. And I wonder, and then I think on the other hand, there's, people with no medical training who titrating, the chemicals is not in their toolkit. And then I think about how you came from being a counselor to a social worker, and maybe how that's influenced your practice, but also, just is that a fair dichotomy to set up between, there are psychiatrists out there who really over rely on medication as a solution and ignore a lot of lifestyle interventions, and those are the people who are just writing the prescriptions, right?
I mean, it reminds me of this when I was I was practicing medicine. I was a psychiatrist, and I was meeting with a couple, and I said, I think that your husband could really benefit from psychotherapy. And she said to me, "Are you going to hook us up with a social worker?" And I said, "Well, I think that I should see him for psychotherapy." She said, "Aren't you a psychiatrist?" I said, "I am." She said, "Can they do psychotherapy?" I said, "We invented it." But it's sort of like in the public that the psychiatrist is here for the medication, and then you get referred out to a therapist, and there's probably something very transactional about that. It's more expensive to see me than it is to see a social worker, maybe. But I mean, I think that in the same ways that we don't look at our coworkers as FTEs,
Right.
that if you look at a patient as an object to be analyzed and chemically manipulated, then you're only looking at a tiny slice of this.
And you're also overinflating the importance of what you've learned, that you have this magic power that you just put. But there are a lot of people who have that hubris.
Somebody said something about psychiatry and, it wasn't real medicine. I said, it is the most grandiose branch of medicine that there is, because here's what I'm going to do. I'm going to say the most complicated organ in the universe, in the entire universe, is a human brain. And I am going to change it without touching it. That is grand, but that's really what psychiatry is. I mean, I think the medications can be a tool, but relationships change your brain. The reason that I react to the world in the way that I do and the way that I establish relationships has very little to do with what happened in October of 2025. It had a lot to do with what happened in the late 60s and the early 70s in my life, where I, as a human, learned, not always correctly, but learned how to function in the world and what I could expect from the world. And so, all of us at those early formative years, we learn the rules. What are the rules for life and what can I expect from the world? And unfortunately, a lot of people from their caregivers learn things that aren't accurate, right? Uh, caregivers say things to children, and the child just inherently believes it's a fundamental truth. And I give the example of this that I, you know, I believe that my name is Dewayne, right? Right? We talked about the interesting spelling of my name. And so if I believe that, the people who told me that my name was Dewayne told me a lot of other things. But I wholeheartedly believe that my name is Dewayne. And that if I need a therapist who says to me, your name's not Dewayne, your name is Thomas. Well, no matter how much I believe that my name is Thomas, 3 years from now, if I'm in a crowd and someone shouts the name Dewayne, I'm going to turn around and look, right? Even though my therapist and I have decided that my name is actually Thomas. So I think that, I mean, that's a lot of what psychotherapy and that relationship is giving patients a safe place to examine their beliefs and to see where they come from and to see if they're accurate. You know, is this actually who you are? That, you know, that, you know, and if a patient's caregiver gives them you're not important or you're not smart or you're not attractive, then it creates a story for patients and they repeatedly live their life telling themselves that story. And I think if you have a safe relationship and a chronic relationship with a patient, together the two of you can question the validity of those stories. I think part of the thing that has to happen, like in long-term relational practice of psychiatry, is I train patients to be their cheerleader, their own cheerleader. And I would just point out data and say to patients, listen, you're 45 years old. Every challenge that life has presented you, you have succeeded. Here you are, you have survived. And so I don't know what's happening next week, but if I'm a betting man, I'm betting on you. Based solely on the data of your life. So far, you've had survived everything. And this next challenge, I don't know what it is, but my guess is you're probably going to survive that too. Not because I like you, just based scientifically on the data so far. And like, you know, teaching patients to embrace that survival that they've had and their success that they had and start rewriting the stories that they tell them about themselves. And that's, you can't do that in a 15-minute med check. But I don't know, sort of soapboxy, hallmarky.
Well, any final thoughts? Speaking of relational healthcare, I know that today we've got our department connect, so you got to go mingle with everybody soon. But
I mean, you know that people who don't know what that is, that one Friday a month we close the entire practice down, and all of the departments get together with each other, and we do some administrative stuff, and then we do some educational stuff. That is very not transactional, right? Because this half a day that no one is generating any income from this organization is phenomenally expensive. But we believe it's important enough to spend that money to do that, because this is where relationships are strengthened and people learn. I mean, it's worth the investment, although, you know, it's difficult for our bottom line to take a day where we close the business down and just hang out. I think it's
well, it's not. I mean, it's not good. I mean, quite frankly, at our current size, I can quantify it. Like that is every time we do that, again, current size, because the bigger we get, the more expensive it is. But that's about a $25,000 afternoon.
Right.
But I think it's worth. I mean, I don't think it's worth it. It's undeniably worth it.
It's
and
absolutely.
I would also say, like, look, you know, let's go head to head with some of these private equity backed, you know, companies. Somebody makes a lot of money on it, but then someone's left holding the bag and, you know, runs away because they can't make more money at some point. So I'll sacrifice that money today to be able to be sustainable in the future and be a place that people want to work and the patients trust us and that they can come back to us, anytime, and we're going to be with them as long as they need.
And I think that like this day, not just education, but, it's a chance for us all to hang out and be together, I mean, you and I have talked some about the mothership, right?
Yeah.
And so, I've been thinking a lot about that and where I want it to be the mothership where we're all in the same building. And I was like sort of wondering, like, why do I feel like I want that and need that? And I'm going to tell you why. Because when I was a kid, my grandmother, and she lived very close to me, she had like 12 kids and they all grew up and had lots of kids. And we all, for the holidays, would go there. And I mean, it would just be hundreds of people and cousins and aunts and uncles. And I think that in a way, these nodes, or we don't know the word yet.
We're
right?
going to work on that. Yeah. Site.
It's like a family, and then the kids become adults, and now they go have Christmas at their house, right? And then every so often, everybody gets together, at grandma's house. But now the primary family becomes that, and that's super important to that family. And it doesn't lessen the other thing. You're still part of the whole, but you have just like a part of that. And I think that, Friday afternoons, the third Friday, is kind of like a family reunion at grandma's house.
The whole family. Yeah, that's right.
Well, so thanks for doing that.
Well, Dr. Book, thanks for coming on, and I'll let you get out there and have fun. Sorry to miss everyone today, but I'll see you next week, and we'll get back and talk ADHD and substance use another day.
That sounds great. Be safe on your travels, Tripp.
All right. Thanks a lot. See you, Dr. Book.
Okay.
Thanks for listening to Flourish by Advita Health, a podcast about the art and science of living well. Learn more about our work and explore all that we do at advita.health. That's ADVAITA.health. Until next time, here's to living the good life together.